My name is Paolo Giorgi Rossi. I'm an epidemiologist. I'm from Italy and from Reggio but we are here for, okay. So the EUCanScreen joint as a main aim to favor the implementation of the European Council recommendation about screening issued in 2022. The recommendation, the European Council recommendation, as a central point the idea of risk-based screening when it's possible and appropriate. And so the joint action has a whole work package dedicated to the risk-based screening. The work package is structured in 7 tasks, and there are 4 tasks that are dedicated to each cancer side. So 1 for cervical cancer, 1 for breast, 1 for colorectal, and 1 for the new screening, so prostate, lung cancer, and gastric cancer. And then there are, okay. And then there are 3 I think we can also go into Zoom if you don't.
Yeah.
There were some nice animation, but it doesn't. So this is my disclosure. Can you show the next one?
Slide.
Okay. So you see the 4 cancer-specific tasks and tasks that are linking together all the tasks, the cancer-specific tasks. And one is about communication issues. One is about the integration between primary, secondary, and tertiary prevention. And another one is about the conceptual framework of risk-stratified screening. And this is what I will present today. Next slide, please. Okay. What are the aims of the conceptual framework in this? We want to describe the rationale of the risk-based screening, the essential elements of that we need to build the risk-based screening, identify general issues that epistemological issues that we need to evaluate a good model for risk stratification, and what we need to demonstrate the efficacy or effectiveness of risk-based screening compared to a standard screening. To harmonize the language across all the tasks, and so we made a glossary, and defining common steps that the cancer-specific task should do, so a survey of existing screening, scope review, and analysis of the guidelines, and producing a toolbox for implementation, and identifying some common topics that should be considered in each cancer-specific task, and afford issues about how to monitor risk-based screening, how we have to change the indicators that we already have for the screening product. Next slide, please. So the methods, we started with a scope review. We conducted an online structured brainstorming, collaborating with all the bodies that are involved in the joint action. We conducted a Delphi round methodology and a final plenary discussion in Turin in May 25. Next. So the rationale of a risk-based screening. The starting point is that the benefits of screening can only be enjoyed by those that have the disease or will have the disease. While the harms of screening are proportional to the intensity of screening and usually affects all the screenings almost independently of the prevalence of the disease. Therefore, benefits increase with risk, while harms are almost stable. And so you see the balance that increased benefits when you have higher risk, and while the harms are quite stable, and at a given intensity, the screening has more net benefits if the risk is higher, or at a higher risk, we can apply a more intense screening, or at a lower risk, a less intense screening, maintaining the same balance. Next, please. There are some situations in which the screening only implies a different occurrence of the same disease, exactly. And in this way, we can only improve the efficiency of screening. So the net benefits will increase as described. But then it's the situation that I described before. But in some cases, we have also that different risk underlies a different disease. And this is typical, for example, in cervical cancer screening. You see the graph in the right low part of the slide. Without an emission, it's a little bit more complicated. But let's imagine that the green one line is a progression of a CIN3 toward cancer led by HPV52, and the red one is led by HPV16. The risk, the probability of progression, is also linked with a faster progression. And we know that the average onset of symptoms of cancer due to HPV16, 18, and 45 is less than 10 years younger. It's more than 10 years younger than other high risk. So it underlies a different disease. So probably a different interval, if we have a screening in between the two, we can prevent more cancer if we know that the woman is infected with HPV16, and we can have a longer interval if we have another type of screen of HPV. So in this case, different screening, starting age or interval or type of test, can change the efficacy of screening and not only the efficiency. Next slide, please. This concept has been developed especially by Riga. So the conceptual framework, the essential elements are a valid information about individual risk. We need information to classify the people, and grouping people in homogeneous risk and coupling the groups with a certain screening protocol. Next. What can we change in screening? We can change the age to start and stop screening. We can change the interval. We can identify groups at the so low risk for which probably screening is not beneficial at all at any age. Or we can change the tests or combination of tests. For example, in breast cancer screening, we can define a threshold to from mammography to MRI, or we can change the test, the threshold for defining what is positive or not, the threshold of a given test linked to a different management. For example, this could be done in colorectal cancer screening if we take into account of the previous results, presence of hemoglobin in the previous screening, or is the thing that the new Swedish guidelines for cervical cancer are doing according to age and type of HPV infection, they change the management. So the same results will change according to the baseline risk in terms of positivity or needing triage, needing colposcopy or follow-up. Next slide. The screening is a pathway, and we can apply this recertification at any stage of the pathway. And for example, we can now, it's very light. We are missing all the people that are light blue. They disappeared, but there should be some light blue people there. We can apply the recertification before screening, after screening, at the second round, knowing the previous rounds, knowing the attendance or not, after the results to triage the woman or the people, or after the results before defining the treatment, or if we treat, we can define also the follow-up. Next slide. The common topics that we identified through the brainstorming and Delphi round pertains to these main 5 or 6 groups. And the first one, next slide, please, is the utilitarian versus individual approach, and the societal versus individual advantages. It is obvious that if we, not that obvious, but a well-done risk-based screening should identify people at higher risk where we can intensify screening, but also if we have more cancer in a group, we have less cancer than the average in the others. So probably we need data identifying some group. And this is how we try to optimize the allocation of the resources. But this means that some people will receive less. This is appropriate because we are trying to maintain the same balance between the efforts and what we can gain, and the harms and benefits. But if the value that a person gives to the harms and the benefits is not the same that we do, probably it cannot accept the intensification. And this is a very important problem. And it has something to do with the health consumerism and the way to balance autonomy and public health benefits. Next slide. As an example, I also report the common topics about access and equity. It is important to understand that there could be some linkage between the source of information and equity, and this will impact on how the pre-stratification performs and in the real life. But also there is an issue of health literacy that is needed to understand the re-stratification and to accept or not the re-stratified screening. Next slide, please. And another group of common topics that we identified is the psychological impact. And so how to deal with stigma and how to maximize the psychological benefits also that we have from risk stratification, not only how to prevent the anxiety of risk communication, but also how to handle with the user perception of risk stratification and financial costs. This was very important. In my PEPs, we had experience about this, and people perceived the intensification as a ultimate attempt to cut costs. Next slide. We also identified 4 domains of our organizational impact: the data availability and management, the IT issues to manage the invitation and the follow-up in a risk-stratified manner, and the availability of biobanks and training and education for risk communication and management of the screening, risk-stratified screening. Next slide. I focus only on the IT issues because, yes, we need more powerful IT tools, but also more flexible, because the risk stratification is going to change rapidly. We will have the risk stratifiers are evolving rapidly, and so we needed to change the guidelines much faster than usual, than before. And also, we manage this problem of how to change the management. If a woman, in my test, for example, changed the risk during the in between of the 2 intervals, if they notify a new biopsy outside of a screening program or a new case in family history, this is very difficult to manage. So the next slide is the last one. And first of all, this is the first draft of the document. At the end of the project, we will integrate with all the results of the elaboration from the cancer-specific tasks. But I want to focus on that most of the research until now focused only on the high-risk group and what should we add on that. But it's obvious that if we have a higher risk, we have also lower risk than the average. Otherwise, the arithmetical sum doesn't give the same results. And so we have to, if we want to really implement a sustainable risk-based screening that increase the efficiency and the effectiveness of the system, we must look at both the sides of the distribution of risk and for the issues on how to intensify screening where we can get more, but also how to de-intensify and how to communicate the intensification in a proper way to the public. Thank you.
Technical issues that you have recognized.
Thank you, Marcis. For some of you that saw the video, I might look familiar. Yes, that's me. You've also noticed that I might be able to catch up on time because I talk quite fast. I'll try to pace down a little bit. As Marcis said, I'm going to talk about risk-based screening modeling, but I'm going to focus more on the general message, and I really want to sort of start where Paolo ended by using a quote that I use a lot when it comes to screening, and that is that all screening cause harm, and only some screenings are useful. And I want to illustrate that based on the example. This looks great, perfect, thank you. I want to illustrate that with an example from our Dutch colorectal cancer screening program. And in that program, we screen 1.5 million individuals every year. But of those 1.5 million individuals, only 18,000 individuals, and it's a huge number, it's an important number, but only 18,000 individuals are actually detected that year with a relevant finding, so either colorectal cancer or a precursor lesion, which means that the other 1.32 million individuals experience anxiety, experience the burden of collecting their stool and sending it to the lab, and some of them even experience the false positive result and having to undergo follow-up testing, which causes, of course, even more anxiety. And of course, these harms are manageable, and if you look at what the program achieves, it is something that we consider still a very good balance, because using 18,000 cases, we see that eventually, now that we've evaluated the program, we can prevent almost half of the deaths due to colorectal cancer. So it's really important, but it's also, I would say, a responsibility of all of us involved in the field of cancer screening to try and see if we can reduce the harms for those 1.32 million individuals that did not experience benefits from screening, at least this round. And of course, at the same time, there are some in those 1.32 million that were actually missed by the program. So also we want to do better for these. I think that's sort of what risk-based screening is all about. Just to make it a little bit more concrete, what are we talking about? Well, for false positives, for harms, we're talking about potential complications for harms, and we're talking about potential overdiagnosis for harms. But the benefits is the reduced morbidity and the reduced mortality from the disease. So how can we risk stratify? Well, we have many options available to us. We can stratify based on individual risk factors, such as sex, such as age, such as lifestyle or genetic predisposition. And of course, we now have these more complicated, but also comprehensive risk prediction models, including multiple factors at the same time. And then we have the option, as Paolo was also alluded to, of screening history. And this sounds, especially those risk prediction models, is something that's really, I would almost say, hot right now. People are really looking into that. And we have two examples. For example, I come from the colorectal cancer field, so you will find my examples are quite often for this disease. But in the colorectal cancer field, there's actually two very well-established models. One is the EUCanScreen model, and one is the model by investigators in the United States, the GECKO model. And both of them have incorporated demographic characteristics and lifestyle, and the GECKO model also includes the genetic information into the risk prediction model, and based on that, they predict an individual's risk of colorectal cancer over either 10 or 15 years. And if you look at the areas in the curve, they seem quite promising, and you feel like, oh yes, we can really make a difference. We can distinguish individuals with a high risk and individuals with a low risk. If you look at this from a population perspective, it starts to look less beneficial, because we used what we call our decision model. This is a model that can estimate the benefits and harms of different screening strategies and also the costs and effects. If you use that model and we compare a situation of uniform screening that you see on the left-hand side, and then each bar represents a different outcome, so costs, the number of follow-up colonoscopies needed, or the number of quality-adjusted life years gained, and you compare on the population level what happens with uniform screening, and then if you would use risk-stratified screening that would cost the same as uniform screening, you would only be able to gain 0.1% additional life years gained on a population level. So is it really worth all the hassle? Because there is quite some hassle involved in doing risk-based screening if you see these numbers. Well, my suggestion would be probably not based on these risk prediction models yet, but there are other options. So currently what we're facing for the implementation of risk-based screening is that these models do not have the reliability needed to be actually implemented in practice, and therefore the expected benefits on a population level are currently negligible. And as I said, the hassle. What is the hassle involved? Well, you have to quite extensively start to collect additional data. You have to know that people's lifestyle. You have to collect blood so that you can do the SNPs. There's a lot of things that need to be done with the potential challenge of confusing people or thinking it's too much trouble, and they're not showing up for screening anymore. So that's important to keep in mind. We only reduce screening effectiveness if people decide not to show up anymore. And of course, if you're going to screen based on lifestyle, there is the potential for stigmatization and for discrimination. So there's all kinds of barriers that are involved. But there's also what we call more the low-hanging fruit. And that's what we're going to focus on our modeling at first in the EUCanScreen project. And we're thinking about the low-hanging fruit. We're thinking about data that is already oftentimes collected within the existing screening programs, so that there's not so much additional data collection needed. And on top of that, these are variables that have much higher predictive performance at this moment than the extensive risk prediction models for many of the diseases. So you'll notice I'm not always as nuanced as I should be, because I know that for some diseases the risk prediction models are better than for the others, but just forgive me my lack of nuance in that respect. But there are actually quite a few things that are available already within the existing screening programs that we could use to optimize and to improve the balance between the benefits and harms. And a very obvious low-hanging fruit for the breast cancer screening program is, for example, using breast density. We know that people with dense breasts have up to 1.5, 2 times higher risk, and that the mammography is not performing well in these individuals. For cervical cancer, obviously, HPV vaccination is making the risk completely different between women that are vaccinated and women that are not vaccinated. For colorectal cancer, there is convincing evidence with risk prediction using just age, sex, and fecal hemoglobin concentration, resulting in discriminatory power that exceeds by far that of the complicated risk prediction models based on genetic and lifestyle information. For prostate cancer, we have a similar thing where the level of the PSA, but also changes in PSA, are very predictive of having cancer and also for having aggressive cancer. That in combination with age. Lung cancer, well, in order to be eligible for lung cancer, you already need to collect information on tobacco use if it's not available. But once you have it, you can also use that information on tobacco use to tailor the screening interval, for example. And finally, for gastric cancer, we know that there's difference, and the EU currently recommends gastric cancers in countries with high risk. But then within each country in the EU, there are subpopulations that, because of the country of origin they came from, for example, are also exposed to higher levels of gastric cancer risk. And so these could be individuals that could be targeted in lower risk countries. For the Netherlands, we actually already have done some of our modeling work to illustrate what the benefits could be of each of these scenarios. And this is actually a paper that was done by a colleague of mine in 2021. And recently, this paper and all the follow-up work that we've done afterwards got very big attention, because in the Netherlands right now, the government has decided that they want to try and speed up the implementation of MRI screening for people, or for women with dense breasts. I told you I talk fast. That's based on this initial analysis where we showed that if you look at what the benefits of mammography screening every 2 years in these women is, and what you can do if you switch just to MRI every 5 years, you could almost double the benefits of the screening program in these women. So it has a huge impact. So this is for breast cancer. This is an analysis that we did for the Netherlands, looking at the impact of screening in vaccinated and in unvaccinated women, and if you just put them all together. And what you see from this graph, let's see if this works, yes, is in green is the benefits from screening in vaccinated women. Of course, because their risk is lower, their quality-adjusted life years gained is also much lower. There's less to gain in these individuals. And if you look at the unvaccinated women, they have a much higher risk, so there's much more benefits. And if you then look from a cost-effectiveness perspective, what is optimal to offer them screen-wise, actually vaccinated women should receive only half of the screenings, or maybe even less, than unvaccinated women. And if you would just take the average, then neither of them would be getting their optimal strategy. You would be over-screening the unvaccinated and under-screening, other way around. Over-screening the vaccinated and under-screening the unvaccinated women. This is work that we've done looking at the fecal hemoglobin concentration, so the level of blood found in the stool for people participating in a colorectal cancer screening program. And what you see there is that, at least in the Netherlands, the government had always communicated a negative result as saying there's no blood in your stool. But we all know that's not true. It just means there is a level of blood or no blood, but that level of blood is below a certain threshold. But when you look at the risk of people that are just below the threshold versus the people that have no blood in their stool whatsoever, there is a difference in risk. They're all low risk, but there is a difference in risk. And so what you see is what we currently do is, well, it's hard to see, but there is green 222 there, which means that all risks levels in the population are receiving screening every 2 years. But what you can also see is that if you move that to a strategy where you would screen the people without any blood in their stool every 2.5 years, the people with intermediate levels of blood every 1.5 years, and the people that have very high levels of blood, high, still below the threshold, but high levels of blood, every half year, you would reduce cost and increase benefits. So there's really possibilities to improve. And then finally, this is the prostate cancer. And here the same thing you see happen. If you, rather than screening everybody every 2 years, would screen individuals that have a PSA level under 1 nanogram to 8 years instead of 2 years, you could reduce the number of screening tests by half, while maintaining 97% of your benefits. So you would still gain 97% of the quality adjusted life years gained if you would screen everybody every 2 years. So this is a huge impact. For lung cancer, this is quite a complicated slide, but the take-home message that I want you to know is that if you would just consider age and smoking history to determine whether somebody receives a 2-year interval rather than a 1-year interval, you would be able to reduce 20% of the CT scans that you require in an annual program for everybody, while maintaining basically all the benefit. So there again, you can really make changes. And this is the example of gastric cancer screening in the US, where we looked at black and white men and women. And of course, what you see here, the black line is what happens without an H. pylori test and treat program, and then the colored lines are test and treat programs at different ages. And you see the same pattern over all the groups, so it is effective in all groups. But the risk difference between, for example, white men and black men is so large that for white men I would have to screen 2,000 people almost to prevent lung cancer death, whereas for black men, it's still a lot, but I would have to screen 600 men to prevent one gastric cancer death. So there's a huge difference in that balance between the harms and benefits of screening. So what we're going to do in this EUCanScreen project is take these analyses that we've done mostly for the Netherlands, but also look at these strategies for other countries to see how robust they are and if we see similar findings in other countries. But of course, that doesn't mean that if we model it and we show that it works, that we're ready for implementation, because there's quite some other aspects that I'm not going to linger upon, because I know there's somebody here that can do that much better than I can. So with that, I end my presentation. I want to thank you very much.
Who has agreed to give a talk on this.
Thank you, and I would like to thank your previous speakers, because I think you made my talk very easy in many senses, and I can speak quickly. But yeah, my name is Signe Mezinska, and my main job is doing ethical reflection, and I work here at University of Latvia. And seems that it doesn't work for some reason. Oh, okay, it works. So we have actually, if we speak about ethics, ethical and social aspects, that on one hand we could say that we have standards. We have very good standards, like we had Wilson and Jungner, and then there are improved versions. And if you look at these screening criteria, they, of course, they include main ethical issues like screening should respond to recognized needs. or objectives should be defined, or there should be quality assurance, or equity, etc., etc. So maybe we could stop here, because we have very good standards. But with ethics, it's never ever so easy, and I would say that we have a good plan, meaning we have blueprint or standards, but the real problems come always when we have to implement those blueprints, or we have to build a building following the blueprint. So, or if we use metaphors, another metaphor might be moving target. The implementation of ethical principles is always a moving target in healthcare, including screening. So I will start with this example, which is not from Europe, which is also maybe it's around 10 years old, but I think it's still a very good example on what can go wrong. And it was very broadly featured in the US. This is New York Times article on this issue. It was a story about Jennifer. She was 39 at that time, and she pursued genetic testing due to her grandmother's early death from breast cancer. So she was at risk, of course. But then, in the process, she was just offered expanded testing covering 20 additional cancer-related genes, and no mutations were found in breast cancer genes, but one was linked to high gastric cancer risk. And theoretically, the risk was so high that if she would have cases in family, actually maybe doctors would even recommend to remove the stomach. But the issue was that she didn't have cases in the family. No one asked her before doing this test whether she has risks in family, and it all ended up as a disaster, because now at the end, and that was the whole issue in the article and public discussion, she got some information about being at risk, but there was no action to do, and actually she ended up harmed and with much more uncertainty than she was before. So what we can do, and I will of course not invent anything new. Actually, I will go to 3 topics which were mentioned in previous talks. I'll speak about informed consent and respect for autonomy. I'll speak about equity, and I'll speak about risk-benefit ratio. So, but to give this broad context, I'll go back to European regulations. And what we have in Europe, we have Oviedo Convention, which is a Council of Europe document, which is legally binding for our states, and we have ratified this document, and for sure this document gives very good framework and standard how we should approach healthcare. What it says that intervention in the health field may only be carried out after a person concerned has given free and informed consent to it, and the person shall beforehand be given appropriate information as the purpose and nature of the intervention, as well on its consequences and risks. Very clear and very unclear at the same time. Because if we speak about information in healthcare, another document, UNESCO Convention on Bioethics, uses the term adequate information. But what do adequate information mean in case of risk-based cancer screening, for example? So there are a lot of challenges in giving adequate information, and one is complexity of risk information in this case, especially if we involve genetic or epigenetic risk stratification, but also other stratifications. It might be very complex to explain it, and health literacy was mentioned already, of course. So complex information can hinder understanding, especially for individuals with lower health literacy, limited education, or language barriers, because as it was mentioned, in some countries there are ethnic groups, specific ethnic groups which are more at risk. And for example, language barrier might be quite a big issue. So not to mention such complexities like it's quite clear that AI is and will be used more and more in stratification, in evaluation of risks, and it's based on the research we have right now, it's not easy for healthcare experts to understand and explain the use of AI even for themselves. So there are many challenges, but if we don't manage to give this information, then we can end up with lower adherence. So what are potential solutions regarding informed consent? One is recognizing that informed consent is a process, not a single event. Like screening is a process, so is informed consent. And every time information changes or our knowledge increases, we should really think how to bring this knowledge to each individual potential participant of screening. Then there are very particular developments like patient decision aids, which could help. Those are tools developed to help patients make specific informed choices in health-related decisions that align with their own values. So each risk-based screening should also maybe have such a patient decision aid. And of course, translations, adapting information and consent materials to different literacy levels, cultural backgrounds, and values. And not to forget, training professionals, because sometimes we train professionals in content or medical information, but we forget to train professionals in communication skills and very specific ways how to provide information. And going back to history of informed consent, for quite a long time there are these three information standards defined in the context of informed consent: professional, reasonable person standard, and subjective or individual standard. And there is a broad discussion which standard should we use. More or less consensus is that something in the middle between reasonable person standard, which focuses on the needs of a hypothetical reasonable person, and subjective standard, which asks what information is relevant to the actual patient, considering individual values, experiences, and specific concerns. So somewhere in the middle between these two, that might be the best current solution. But how to implement it, again, it needs very, very tailored and skilled approaches. Fairness and equitable access to screening, which is again mentioned in the Oviedo Convention, parties taking into account health needs and available resources shall take appropriate measures with a view to providing within their jurisdiction equitable access to healthcare of appropriate quality. It's a very complex question because it's not only, for example, as it was mentioned about equity between high risk and low risk groups. It's also about some or many neglected groups in a society. We did a survey about implementation of patient rights in Latvia last year, and what we got in a sense very self-obvious result that those groups in society who have very good health literacy, who have good education, who have higher income, etc., they are much more successful in implementing their patient rights. And in comparison, those groups which have vulnerabilities, different kinds of vulnerabilities, it might be social status, it might be health literacy, it might be different kinds of disabilities, they lack implementation So those who are in good situation are, they will be in good situation. And the question is how to really include in risk-based screening also individuals from marginalized communities who anyway will be less likely to receive or comprehend the information about their eligibility for risk-based screening. So it's not only about high and low risk, it's also about in which part of society you are, and it will be overlooked that screening initiatives risk reinforcing existing health disparities. And it means that really the screening must be embedded in a framework of ethical responsibility that promotes equal opportunity for health, and equity must be at core in very different meanings. What it requires, or what are potential solutions, one is integrating risk-based screening with a nuanced understanding of social context, and the second, stakeholder engagement, including patients, community representatives, ethicists, is essential to ensure that screening programs reflect diverse needs and values. And I think it's great that also today we have a session at the end in which we'll look at patient involvement. And the last but not least, really maybe the biggest field is risk-benefit ratio, which was covered in previous speeches very well. If you look at the Oviedo Convention, it says that one is primacy of the human being, and that goes together with the question which was asked about personalized medicine. Interest and welfare of the human being shall prevail over the sole interest of society or science. That's what the Oviedo Convention says. However, right now in Council of Europe, I'm a member of CD Bio, there are more and more discussions about communitarianism and role of social interests in shaping the healthcare. So maybe there will be some changes in this particular point. However, of course, from point of medical ethics, patient is in the center. And the second, I showed it already, but if you look once more about to this point about information, then consequences and risks, that's a major part of information. I will not repeat, I think it's very close to the slide which was already showed what are the benefits and what are the risks. If we speak about potential solutions to ensuring risk-benefit ratio, one is to fully evaluate the risk-benefit ratio of risk-based screening. Research must include the voices and experiences of participants again, and participant views help assess whether risk-based screening is ethically and psychologically acceptable. And I think the MyBBS project, which is also represented today somewhere in the program, is a wonderful example of how the risks and psychological risks can be really measured in randomized trials, and I think this is really good practice example how to do it. And also not to forget that participant experiences can also guide the development of effective communication strategies. So what are at least some conclusions? One, we have reflection on ethical and social issues in the context of risk-based cancer screening, and we saw it today also in the context of EUCanScreen. But there is less clarity regarding the best approaches to address these issues, because as I said, it's a moving target. For example, COVID-19 influenced public views on vaccination in a way we cannot predict, and we the same might happen with concept screening. Need for more sharing of best practices. We need, maybe EUCanScreen needs like a catalog of best practices, how to address these issues, and more and more patient and public involvement is a key prerequisite. So we don't know what will be there around the corner on the way, but at least we are on the way, and we are reflecting on ethical social issues. So thank you.
Thanks, Signe.